Assalamu alaikum. Today we are discussing the right-sided pyeloplasty in a very thin young lady. Here you can see that the tip of the trocar is engaged here, and now we can direct this tip towards the empty space and place the trocar or the port without any fear. Now on the right side, in the right hand, we place this one, the right-handed port, which is 5mm working port under vision, which is really very easy to place. And then the third port in the left hand is also 5mm. Here I decided to place the first port. You can see in the diagram that the first port that I placed was in the right iliac fossa, and the reason for that was very clear, that I knew that if I was placing 10mm port, and that is the first port for the camera, and that is placed blindly, then obviously there's highly likely chances of injuring the kidney or the renal vessels or the liver or a major vessel, because I could feel the aorta through the abdominal wall of the patient. So I deliberately placed, at first I counseled the patient about the pneumoperitoneum. That will be really difficult to create a pneumoperitoneum. Once we created pneumoperitoneum with a varus needle in the right iliac fossa, and then I placed this 5mm port in the right iliac fossa for the pneumoperitoneum, as well for the gas, as well as for a 5mm telescope, so that I can place the working ports and the main camera port under vision, so as to minimize the chances of injury. So pre-operative planning, per-operative planning, change of plans, all these have to be really active during the process of or the procedure. So always keep these innovations and new things on your table, and be prepared for the things that you have to do in a non-conventional way. So here is this right-sided pyeloplasty. We know the indications for pyeloplasty are that if the patient is symptomatic with a PUJ obstruction, if there is a decrease in the GFR over a period of time, if there is decrease in the renal parenchyma over a period of time, if there is some anatomical abnormality, then the pyeloplasty needs to be performed at the level of the PUJ. Here what we are doing is that at first I assessed, after placing the camera port, I assessed the position of the liver. At first I thought that I'll have to retract the liver as well and place another port, but once I dissected away the peritoneum from the liver, I realized that this mobilization of the liver and retraction of the liver may not be required. Here you will see that there is, yes, here you can see the lower portal vessels leading to PUJ obstruction. That's the vein upstairs. And so after careful dissection of the renal pelvis, we decided that the port for the liver retraction is not needed, so I didn't place that port. Now as we know that there is a lower polar vessel, a vein and an artery, which is impinging upon the PUJ, leading to PUJ obstruction. So now we have to dissect the pelvis above the vessels and the ureter below the vessels. We have identified the pelvis, and now we are trying to identify the ureter as well. So once the ureter is there, you can see that ureter is having peristaltic movements. So we have found the ureter. Now we are bold, and we know in our mind where the position of the ureter is. So we can dissect the tissue anterior to the ureter easily. and boldly. So the first principle here, the ureter is visible very near to the gonadal vein as well as the inferior vena cava, as the normal anatomy is like that on the right side. So the first thing in a pyeloplasty is that you should not mobilize or denude the ureter for longer length. You should mobilize the ureter just in a length or at a distance so that the anastomosis can be performed easily. That's the gonadal vein, you can see. The other thing to preserve the vascularity of the ureter is that if you are mobilizing the ureter, so please do that away from the ureter. You should not peel off the periureteral sheath. In that periureter, now you can see the pelvis and the ureter very clearly. In the periureteral sheath, the blood supply is running longitudinally. The ureter, mind you, does not have its own blood supply, like there is no ureteric artery. So it is actually borrowing the blood supply from here and there. So those small vessels, when they come, they come along the perpendicular to the ureter, and then in the periureteral sheath they run along the length of the ureter. So if you mobilize a very long length of the ureter, most probably you will compromise those small vessels. That is number one. And number two is that if you have denuded the ureter too much, which means that you have removed the periureteric sheath as well, then it is quite sure that you have devascularized the ureter. And the first principle which you have to follow is that one, and failing to abide to this principle will lead to failure of the procedure. Now, once you identify the pelvis above the ureter, above the vessels, and the ureter below the vessels, then you have to mobilize the urinary system. I mean, the ureter and the pelvis should be mobilized from the vessels rather than trying to dissect the vessels themselves. Because if you are trying to dissect the vessels, it is highly likely that the vessels will be damaged, and once damaged, supply to some portion of the kidney, and that can be a major portion, can lead to disaster. So always mobilize the urinary system from the vessel rather than dissecting the vessel from the urinary system. Here you can see that I'm peeling off the ureter and the pelvis from that system. You can do that by using a monopolar scissor. You can do that by using a monopolar hook as well. Whereas and that would be more hemostatic as well. However, I prefer to do it without using diathermy. And once you dissect enough, then you have to dismember the pelvis and the ureter from each other. That's why it's called dismembered pyeloplasty, Anderson-Hynes. And once you do that, you make a small nick in one wall of the ureter, which you can identify later on for spatulation. And that is usually on the lateral wall of the ureter. Here, I must emphasize here that I have not excised any part of the ureter, and that so clearance of the peripelvic sheath is important in reconstruction, because that may hinder our stitching. So a little bit of release of the peripelvic tissue or peripelvic sheath is important. And this peripelvic sheath usually also contains blood vessels and supply, but more importantly, it contains the nerve supply. So that nerve supply will be affected if you mobilize the peripelvic sheath as well. So then I have not excised any part of the ureter because I don't feel there is any intrinsic factor. However, if there was any intrinsic factor, then of course it was really small. So that portion of the ureter is going to go to the tip of the anastomosis. So it will not be an active factor in the peristaltic movement of the pelvic-ureteric system. Here you can see that the pelvis is quite thick-walled and is also dilated. And one important thing you must have noticed that I have not excised the lower portion of the pelvis. Rather, I have started from the lower portion towards the upper part of the pelvis. I usually do this in the retrograde fashion, whether on the left or the right side. And the advantage of this is that when this flap, which is in my right hand, if this flap is intact, it is usually easy to grab it and it can be suspended in order to be helpful. So at the spatulated side, on the edge or on the corner, we take a stitch which is outside in, taking care of not taking the posterior wall of the ureter. And then in the pelvis, we are taking the dependent most part of the pelvis inside out, and then they are stitched with each other. I'm using a 4-0 vicryl suture. However, for laparoscopy, nowadays they favor a barbed suture in the form of V-lock, which has got its own loop, doesn't need any knotting. And the other important thing is that it is barbed, so once it is pulled, it does not loosen again. But there are two important things. Number one, that suture is usually the smallest one available in the market is 3/0, which for me is a little bigger for a procedure like pyeloplasty. And the other thing is the cost. So I'm really very comfortable with the 4/0 vicryl suture. So we are doing the posterior wall first. Here I'm grabbing the ureter at the tip only, because the forceps in my left hand is Maryland forceps, which is traumatic. However, I'm not using a full force to grab it, but even then it is traumatic. So that's why I'm holding the tip of the ureter rather than holding the other edges, because this may lead to crushing of the tissue, leading to ischemia and later on the stricture again. I also prefer to perform continuous suturing rather than intermittent suturing. Once we reach the tip of the anastomosis, or the tip of the ureter, I usually take the suture outside. So here the suture has been taken outside, and then another stitch is taken from outside, so that there is a loop formation outside the urinary system, and that can then be stitched outside, so that the stitch is outside the system rather inside. The first stitch is usually a surgeon's knot, so that it doesn't become loose, it remains watertight. And then you can complete 2 or 3 more stitches, and thus we cut the suture. Then I take the tail of that previous suture of the posterior wall towards other side. This makes the wall of the other side right in front of me, and I take one stitch at the corner with a new suture. You can place a small feeding tube and then you can perform suturing to avoid any entrapment of the posterior wall, especially at the corner, because later on it is easy, but the corner is the difficult most portion of the anastomosis. And once we knot it, I usually cut the tails of the both sutures because they are going to be nasty. So, and then I place a 2 millimeter port in the right hypochondrium, and through which I usually place an antegrade stenting. I preload the stent over the guide wire, and then I slowly and gradually push the guide wire with one assistance helping me pushing it from the outside into the body. And once the complete marks are in, then we push the whole DJ stent into the abdominal cavity, and then I place the loop inside the system. This loop can really be annoying at times. However, if it is too much annoying, you can just grab it and place it in the upper calyx, so that it doesn't bother you anymore at any time. One is the bother. The other thing is that you may take it in a stitch. So if you are not confident enough that you have not taken it into stitch, then you must place it inside the upper calyx. Or alternately, if it is not passing antegradely into the bladder, then one can actually, after completion of the procedure, one can place the DJ stent in a retrograde fashion cystoscopically as well. Of course, under fluoroscopic guidance. So here we can see that the first principle of pyeloplasty has been followed thoroughly, that the vascularity is intact. The second principle is that you should not resect the lowermost portion or the dependent portion of the pelvis. The third thing is that the anastomosis should not be under any tension. It should be tension free. And the third thing is that the anastomosis should be, or maybe the fourth thing is that the anastomosis should be watertight. The fifth thing is that the anastomosis must be at the dependent portion. It should be at the dependent portion of the pelvis rather than a non-dependent area. If you anastomose it to the upper portion of the pelvis, then again it may lead to failure. And the third thing is, the fifth or sixth thing is that you drain the pelvic calyceal system under a free drainage system. So we have reached the corner. We have taken the previous loop into the loop of the anterior wall. So it is now beautifully repaired. So the next thing is, so we cut the loop, of course, so that it doesn't annoy us anymore. And the next thing is that the 2 millimeter port that I placed for DJ stent placement, I have a small alligator forceps which can be negotiated through that. So I grab the excised portion of the pelvis in that, so that it can help me suspend the pelvis easily, and I can perform the anastomosis in a continuous fashion in an easy manner. So this is the pyeloplasty, which is transperitoneal. It can be performed in extraperitoneal or a retroperitoneal fashion as well. However, I'm a fond of transperitoneal laparoscopy, so I'll be doing them transperitoneally. But one thing really bothered me about this patient was that the patient was really very thin, very smart, with very small abdomen. So preoperatively, I was not confident enough that I'll be able to complete pyeloplasty laparoscopically. But once we placed the visual ports in a correct position, you know that placing the ports in a correct position, it completes the laparoscopy, 50% of the laparoscopy. So once the ports were placed, they were perfectly placed. There was no injury, luckily, during the port placement. And then the patient was thin and lean. All the anatomical structures were right in front of us. So things became easier and easier with each step. So temperament is the main thing in laparoscopy. If you are in a hurry, please do not perform laparoscopy. If you are tired, please do not perform laparoscopy. So here now you can see that I have excised the portion of the pelvis, and then we complete the anastomosis or the repair by completing the highest point on the pelvis. Since this is the highest point, it is not really important whether you complete fine stitches or just do it roughly, but of course this portion needs to be closed, because slight bit of leak may lead to a lot of problems, including peritonitis and especially failure of the procedure, because urine is an irritant and leads to inflammation. So once that is done, we'll place a drain in the pelvic cavity, which will remain there for 24 to 48 hours. And the catheter, of course, will remain for 7 days. And this patient was discharged on 48 hours. Thank you very much for watching.